Okie dokie. So did anyone get a chance to watch the video from Thursday? Wow, I hear lots of yeses, lots of shaking your head, right? That's funny because YouTube has analytics. I weathered that storm and got that recorded just for you guys, and this is what I get. Well.
That's pretty good.
That's pretty good. Yeah, 16. That was more than I expected. Yeah. Okay, that's what it is. That makes much more sense. Yes. So fun. Anyway, so I won't quiz you guys about that. Maybe next time though, you guys will hopefully have watched it because antiarrhythmics can be a little tough to kind of categorize in your mind the first time out. So I will be asking some questions the next time just to see if you guys have kind of accumulated some of that. But anyway, today we will be talking about asthma and some of our medications for that, COPD. Have you guys covered any asthma stuff anywhere else? You should be at least somewhat familiar with some of the pathophys. We're not going to go super in depth on it. Just talking more about a lot of like the mediators and the pathways in regards to where some of our medications are going to be working specifically. So we'll talk about asthma and then we'll do a little bit on COPD. You'll see that the therapy is somewhat similar, although the steps you're going to take are a little different when we get to there. Anyway, so asthma is going to be this idea of a reversible narrowing of the bronchial airways, right? So we're having a lot of bronchoconstriction occurring, but it's a reversible process as opposed to COPD, which is much less reversible. There you're having actually permanent damage being done to the lungs over a long period of time. You're going to see, especially in patients who are asthmatic, really increased bronchial responsiveness, especially to certain allergens or certain irritants. And then, should be expecting to see, shortness of breath, chest tightness, and all that. You also see thickening of the bronchial mucosa. You're going to see some more edema. You're going to be seeing mucus plugs and things like that forming. So really just a lot of your basic allergic kind of pathway. And so you'll see a lot of the medications you're going to use are going to be kind of focusing on that pathway. We know there's a genetic component too. So a lot of cases, like my mom was asthmatic, so I'm asthmatic. So a lot of genetic things kind of factor into this. It's a common source for doctor's visits and ER visits. Certainly when we get into more of the winter months, our asthmatics tend to really start to flare up, especially because a lot of these cases are not necessarily due to allergens, but they could be also due to like respiratory viruses and things like that. So, at the MORS and the PZD, you start to see a big uptick in your asthmatic patients coming in for acute exacerbations. And so you'll see a lot of these similar therapies being done for each of these kids. But again, when they do find deaths that occur every year, the things that they're going to be finding is they're going to have this kind of contracted airway smooth muscle. They're going to be having these mucosal thickening of the airway, and then these mucus plugs are blocking them. So a lot of the medications we're going to see, one, deal with the acute reversal of these factors, and then we'll also see another group of medications that are going to be working to block this from occurring in the first place. So you have your rescue medications, and then you'll have your controller medications that help prevent this in the first place, right? Again, we kind of talked about the signs and symptoms already. So if you're looking here at the inflammation pathway, the two big factors that are coming about here, we're going to have airway hyperresponsiveness, and we're also going to have airway obstruction that's occurring, both due to kind of the edema and the bronchoconstriction, those mucus plugs happening here, and that's what's going to lead to our clinical symptoms. And so if we can target this inflammatory pathway, hopefully you can target or keep both of these factors from really occurring. So if you could think of like one group of medications that would deal with all the inflammation, what would you think of? A type of medication. Yeah, steroids, right? So we'll see steroids are kind of a cornerstone of like therapy, especially with acute exacerbations. So those will definitely be coming up later on in the lecture. So you certainly have a couple of different phases of an asthmatic exacerbation. So in the immediate phases, when you see these mast cells start to degranulate, this is where you see things like histamine, proteases, heparin all being released. Those are kind of preformed kind of cytokines that are being released from the mast cells themselves. So, the allergen is going to interact with those cells. They're going to have those immediate release of contents. So that's where you start to get some of your immediate bronchoconstriction and edema that's going to be occurring during an exacerbation. Over time, though, you're going to be having mediators start to be developed. So if you look here at the membrane-derived mediators, you can see that cyclooxygenase pathway. You see a thromboxane pathway where we can start to produce things like prostaglandins, leukotrienes. And we'll talk about this pathway a little bit later, and especially when we're talking about things like NSAID-induced asthma and things like that. And then over the course of hours, this is where you start to see new cytokines being produced by changing gene transcription within the actual nucleus. So you can see a lot of interleukins, tumor necrosis factor. This is all going to help to kind of lead to this more sustained kind of inflammation. And when you see patients that die from asthma, typically it's not the immediate phase reactions that are really having the big issue with. It's more of these kind of protracted long phase or long-term phase mediators that are popping up. And that's usually what's going to end up getting them in the long run. So you can kind of see here, if you're looking at the FEV1, that's what was FEV1?
Forced expiratory.
Yeah. Yeah, so forced expiratory volume over 1 second. So when you're seeing an acute exacerbation, you're going to be seeing big decreases in FEV1. That's how we're kind of measuring the degree of the exacerbation. So if you're looking here at the initial phase, you can see a big drop in your FEV1. Again, those preformed cytokines are being released from the mast cells, and then as you go on, you have more of that later term reaction, where say you've given them some of your rescue medications, they're feeling better, but then they can have this late phase reaction where it can be a much more sustained kind of bronchoconstriction and edema happening there. And that's going to be related to a lot of the, at the actual nucleus, transcripting new genes and proteins and whatnot. To have that reaction. So that's where we're going to see why corticosteroids are going to be so important for this, because if you imagine, we talked about anaphylaxis, and you remember, were corticosteroids very fast acting or more slow acting? They're slow acting, right, because they're working at the site of the nucleus. So if you see here, if you give corticosteroids in the early phase, hopefully you can prevent some of those late phase reactions from occurring as well. Just another example here, kind of the activation pathway. You can also see where a lot of our medications are going to be working. Notice here that these are going to be the medications that are used to help control the allergic reaction or the inflammatory reaction. So you see things like our leukotriene inhibitors, you'll see cromolyn, things like that. Glucocorticoids obviously would be kind of like your top tier kind of anti-inflammatory. So they can work to decrease T cell activation, cytokine production. You can see once the pathway kind of starts, that's where you can see different activation of different types of cells. Here you can actually see the bronchiole itself getting those mucus plugs developed. You see the constriction occurring there compared to the normal tissue there on the right. So basically just in word form, kind of what we've already been seeing in some of those pictures. So again, the allergens are going to promote IgE production. IgE is going to be really important for propagating this inflammatory pathway, and we'll see one medication that works to actually neutralize IgE specifically, especially in more severe asthmatics. Those antibodies are going to bind to those mast cells, stimulate the release, especially upon re-exposure to certain allergens, if that's what's kind of kicking off your exacerbation. But again, having histamine, tryptase, leukotrienes, and prostaglandins. So we'll see certain drugs are actually going to work on leukotriene propagation or production. So there'll be another class of medications we'll look at there. Okay, so again, we kind of talked about the early phase. A lot of that's due to the vascular leakage. You're having acute bronchoconstriction. It's all happening there. And then that 3 to 6 hours later, that's where you start to see a lot of those other mediators that are being produced at the start of the exacerbation pop up. So we mentioned not just allergens are what's going to be causing the asthmatic reactions. We can see a lot of viral causes, so especially in the winter time, that's where we're going to see a lot of not only hospital admissions, but ER visits, clinic visits, things like that. Some patients are just going to have kind of non-specific bronchial hyperreactivity where lots of things can kind of set them off. So even things like distilled water could potentially do it, in more of a kind of investigative sense. Exercise, so exercise-induced bronchospasm is a really big thing. Cold air can do it, so especially if you have a virus as you're starting up and you're being exposed to cold air, that both can kind of set you off. And then there's also this other medication we have on here at the bottom, this drug called methacholine. Has anyone heard of this one before? What's it sound like? What other neurochemical does it sound like? It sounds like acetylcholine. So we'll see this actually works very similar to acetylcholine on specific receptors here. And this is actually a medication we can use, administer to patients to actually induce an asthma attack. And we'll actually, based on their response in FEV1, we can see just how hyper-responsive their airway is, and we can kind of get an idea whether or not they're actually asthmatic. So again, bronchoconstriction is not only from the direct effect of those release mediators, you can also see some other pathways, and this is where some of our other medications are going to come into play here. So you can see activation of the vagal receptors. So we'll certainly see some medications that are going to block the effects of increased vagal activity. What type of receptors do you think the vagal nervous system is going to be activating? So is that parasympathetic nervous system? So acetylcholine, what type of receptors is acetylcholine activating? Yeah, so heard muscarinics. That's going to be one of the big ones here. So if you imagine increasing muscarinic activity, you're going to see increase in secretions and things like that. So we have drugs that can block that, can actually help to decrease some of the acute exacerbation. And then even some things like substance P, which you normally hear that more in response to like pain and things like that, can directly lead to smooth muscle contraction. So again, by targeting different mechanisms of action, looking at different pathways, we use different medications in order to help control our patients' asthma. Okay, so the therapeutic approaches we're going to use in the ways that we're going to use different medications. One, we'd like to have acute reverse of the bronchospasm. So here we're going to see our beta-2 agonist. Anyone think of any examples of a beta-2 agonist? No, it's actually a beta blocker. Good thought. Albuterol? Yeah, albuterol is going to be our major beta-2 agonist here. So when we say beta-2 agonist, albuterol is going to be a big one. Ipratropium, which is actually going to be an anticholinergic. We'll go into more in details in these in a little bit. And then also theophylline can fall in this category. Has anyone ever heard of theophylline? Mm-hmm. Yeah, it's a pretty old school drug. You'll see it used very frequently, but every once in a while. You can use things that can help to remove triggers or prevent things like mast cell degranulation. So those are things like cromolyn and etacromol will pop up. And then also the control of inflammation. So we can see things like steroids, lipoxygenase inhibitors, and so we'll talk about these individually as we go along. So just so you guys are familiar with it, we mentioned this methacholine challenge. I see this more done in the investigative kind of world. So like at Nemours, we have an investigation drug pharmacy where we actually have different types of studies. And so one of the big ones is going to be asthma research in pediatrics. And so we actually have patients who will get, basically you want really clear, concrete evidence that they actually have asthma. So they'll actually give them a methacholine test to see whether or not they have this drop in their FEV1. So you kind of give them increasing concentrations of methacholine that they'll inhale. This will activate those muscarinic receptors within the airway, and that causes smooth muscle constriction. So if they have, say, a greater than 20% decrease in their FEV1, then you would say, hey, they're positive for having hyperreactivity. Yes, they have asthma. A lot of times you're not necessarily doing a methacholine challenge to determine whether or not they have asthma. Most of the time it's based on symptomatology and then also response to bronchodilators like albuterol. So this might be something you see done if you're more working like an investigative kind of sense. So I won't ask you to memorize this. This will probably be for another class. You have to look at it. But just to give you an idea of how we determine how severe a patient's asthma is, looking at different types of symptoms, looking at how frequent the symptoms are occurring. This is going to guide us to determining what type of medications we're going to use to help either reverse that in an acute sense or to help control the symptoms from occurring in the first place. We're going to look at things like nighttime wakings. We're going to see how often, especially if they've been previously diagnosed, how often they're using their short-acting beta-2 agonists like albuterol. If they're using it very, very frequently, several times throughout the day, that obviously is a good sign they're not well controlled. And so based on things like interference with normal activities, you can kind of get a good sense of kind of where they're at in the disease progression and what kind of medications you're going to need to institute or to initiate in order to help prevent further progression of that. And hopefully reverse some of that and get them back to kind of a good baseline where they're having good control of their symptoms. They're not having to use their short-acting beta-2 agonists hardly ever. So say, for instance, like when I was a young kid, overweight kid, super nerdy, real bad asthma, had an albuterol inhaler with me in my pocket all the time, 24/7. I used that sucker like 5-6 times a day, right? Just didn't realize how uncontrolled I was at the time. And then finally got on actual adequate controller medication, which includes steroids. Now all of a sudden, I didn't have to use my inhaler at all. So once you have good control of the symptoms, a lot of times you can just even get away without having to carry a rescue inhaler on you, right? So again, just keep in mind that looking at this, you're looking at symptomatology, you're looking at changes over time to see how well they're being controlled, right? So again, our goal is to reduce that level of bronchial responsiveness in the long term. So again, a lot of that's related to airway inflammation. So if we can use anti-inflammatories to help us with that, it's going to be great. Obviously, what's one of the big problems with using systemic corticosteroids? Immunosuppression is a big one. Was there some other side effects?
Healing.
Yeah, wound healing could be an issue. Hyperglycemia, see CNS changes. People can have kind of mental status changes associated with that. Lots of side effects from orally administered glucocorticoids. So you can actually get away with using inhaled corticosteroids, and we'll see later on the different medications that fall into that. But the big benefit here is they're providing local action. You're not seeing a lot of systemic absorption, and thus you don't get a lot of those systemic side effects. So it's going to be much better from a adverse drug reaction standpoint than it is from you still get all the benefits of those systemically administered medications, just working directly in the lungs. So we can do that. We want to prevent or reverse any acute bronchospasm. So this is where our beta-2 agonists are going to come into play. And then obviously, good education on one, how to avoid allergens or certain triggers. If I know I'm going into somewhere that has a bunch of animals, like I know I'm going to have an exacerbation, right? I just know it's going to happen if I'm not on, taking my controller medication like I should. So I need to be warned to, avoid, situations like that. So just keep that in mind for education purposes. So again, looking at your rescue medications or your quick relief medications, the ones that will fall into this category are going to be your short-acting beta-2 agonists, your anticholinergics. We'll see there's some short-acting and long-acting anticholinergics, so this would be the short-acting ones, and then systemic corticosteroids, right? So those are going to be more for acute exacerbations that are not being adequately treated just with beta-2 agonist alone, right? So if I'm using my inhaler a bunch of times, I'm not really getting full reversal of my symptoms, then at that point you'd want to consider using glucocorticoids. And then you have your long-term controller medications, and this will be your long-acting beta-2 agonists, inhaled corticosteroids. You get some other medications like leukotriene modifiers, mast cell stabilizers, anti-IgE antibodies, and then also your methylxanthines. So kind of going in order from kind of most common to least common down that pathway. And you'll see certainly that something like an anti-IgE antibody is going to be more for refractory symptoms that are not really being treated with, not being controlled with anything else. You'll see that's going to come into play kind of as more of a last line type agent. Okay, so our beta-2 agonists, the way that these guys are going to be working are to increase levels of cyclic adenosine monophosphate or cyclic AMP. You guys remember that's the second messenger pathway. And by activating that, I'll show you a picture here in a second how that works. We're going to see that it's going to help to relax the airway smooth muscle. It's going to be a bronchodilator. Usually for the short-acting agents, you're going to see that they work pretty rapidly. They have a very rapid onset of action within several minutes, and they're going to last around 4 to 6 hours or so, right? That's why you might see them use, especially if they have a respiratory virus or something, they might be using it very frequently throughout the day, maybe every 4 to 6 hours or so. They'll start to see symptoms come back. And then you have a couple long-acting agents which are working for 12 hours or more. And the important thing here is that the long-acting agents, they do not have a quick onset of action. They're for control of symptoms. They're not going to be able to treat an acute asthma exacerbation. Okay, that has important mortality consequences, which we'll talk about a little bit later. Actually, the way they're kind of more long-acting is they're actually more lipophilic, so they can actually deposit themselves into the lung tissue, and they'll kind of have a slower release type activity as it partitions out and kind of gets interacts with those beta-2 receptors. But again, not for acute relief of symptoms, only for long-term control. And it's also why you see a lot of those controller medications are going to be administered every 12 hours. That way you get good 24-hour coverage, because again, we know night times are a common time for patients to have asthma exacerbations. I'll talk more about the adverse effects, but some of the big ones are going to be both heart rate and tremor are going to be issues. So do you think you get tachycardic or bradycardic with these agents? Yeah, it should be tachycardic, right? Because while they are beta-2 selective, keep in mind selectivity is only relative. So if you get high enough doses, you're going to be able to interact with those beta-1 receptors and see that increase in heart rate. So you see here, remember that calcium is really important for causing smooth muscle constriction. We talked about that previously when we were talking about calcium channel blockers and nitric oxide and things like, or nitroglycerin and things like that. Here you can see when you interact with those beta-2 receptors by increasing activity of cyclic AMP, that's going to have an inhibitory action on that smooth muscle constriction, so you get that bronchodilatory effect. So beta-2 agonists, the two big short-acting agents are going to be albuterol. A couple different brand names. There, say ProAir, Ventolin, a few different ones. Now, certainly you can have the ones that come in the metered dose inhaler. So if you've ever seen MDI, that's what that stands for. It's a metered dose inhaler. And then what's another common way to give albuterol? Nebulizer? Yeah, nebulizer is a very common way. So frequently, if you're giving, usually like a meter dose inhaler, you squeeze it once, you get 1 meter dose of the drug. Obviously, when you're doing a nebulizer, you're going to get more of kind of a continuous stream of drug over a period of time. So say 20 or 30 minutes or so, depending on the dose and how much you actually put into the nebulizer cup. There's also another drug called levalbuterol. And it being called levalbuterol, what does that tell you about the drug? Yeah, it's that left-handed enantiomer of albuterol. And so people were, the way it was marketed originally is that, hey, we had this one enantiomer, it doesn't cause as many of the side effects, but it still has all the activity of albuterol. So of course they came out with the new drug, new brand name's Openex, and it's way more expensive. But to tell you the truth, when they did the studies, they weren't actually looking at really equivalent doses of the drug. So if you were actually to look at a dose of albuterol, if it was 5 milligrams, what would be the corresponding equivalent doses of levalbuterol? Should be 2.5, right? They're actually comparing even smaller doses than that to, say, 5 milligrams of albuterol. So some people swear by it and say that it absolutely is going to work for them. But say if you're, working in a hospital and you're trying to control costs and work with formulary, it's a lot cheaper just to give them a smaller dose of albuterol. They don't see as many side effects than to give them Openex, right? So just little things to consider there. And then you do have some long-acting agents. So the two most common ones are going to be formoterol and also salmeterol. Again, do not use these alone for asthma. When they did studies looking at this, they were seeing that patients who were on long-acting beta-2 agonists by themselves, without any other kind of controller medications, so no steroids, when they use these by themselves, they actually had increased mortality. So they're kind of postulating people may not have been educated appropriately, or maybe we're trying to use these as rescue medications, because they said, hey, they work the same, we'll use this. And so they actually saw increased mortality. So when they're in combination with, say, like an inhaled corticosteroid, certainly they're fine in that combination, but you may see these more used by themselves than, say, like a COPD patient. Yes?
So when you say that there are studies for asthma and it's only controlling the symptoms, does that mean it's just like puts them at a less risk of developing an asthma attack, or?
The long-acting agents?
Yeah.
They basically prevent the actual bronchoconstriction from occurring in the first place, right? So if I have kind of like a steady baseline activity of beta-2 activation, hopefully I'm preventing that initial constriction from occurring in the first place. Yep. Does anyone know if you have like a British patient coming here, because again, we're in Orlando, so we're a big travel hub. We have a lot of patients from all kinds of different countries coming in. Does anyone know another name for albuterol? I would have given you an A for the class, how'd you know? So salbutamol, if you ever hear salbutamol, that's actually the British version of it. Just like paracetamol is the British version of acetaminophen. So just in case you hear that's what it is. So adverse effects, so because we're activating the beta-2 receptors not only in the lungs, but especially when you get like really big doses, or you're giving, there used to be like an oral form, I guess there still is, an oral form of albuterol that you could administer. You have a lot of side effects associated with that, but certainly, meter dose inhaler is really nice because you get your dose, but you don't get too much. The patient doesn't get a lot of systemic absorption, so you don't see as much of this, but certainly if you're giving big doses via nebulizer, or if they're on continuous albuterol, which we'll talk about a little later, this is where you're going to see more of these systemic side effects. So you'll see activity on the heart causing tachycardia. By activating beta-2 receptors in the vasculature, you can see hypotension, headache, dizziness. One thing I didn't put on here, but it's important, is a transient shift in your potassium. You'll actually see potassium shift into the cells. So you can see a transient kind of hypokalemia. And so that's important if you were to be managing hyperkalemia for a patient. This is actually a good agent to start off with via nebulizer, just because it's so easy, before you have IV access. It can also cause tremors, activating beta receptors on the skeletal muscle, and then you can see hyperglycemia as well, right? So again, these are usually going to be more transient issues you're going to be running into. Usually with the long-acting agents, you don't see a ton of these side effects because again, you're kind of getting a slow release of the drug from the lung tissue, and so you don't really see a ton of systemic side effects associated with those. Yes?
I thought you said that you see it with people who use the nebulizers.
Yes, you're going to see these more. So the short-acting agents are the only ones you see via nebulizer.
Okay.
Yeah. The long-acting agents, those are usually via meter dose inhaler, like dry powder inhaler. So if you've ever seen like the discus, you kind of flip open, you hit a little trigger, and then inhale. So there's a couple different inhaler dosage forms. I don't have pictures of them on here, but you can look up like an Advair discus, and that's considered to be a DPI, or a dry powder inhaler. And so that one doesn't have any actual propellant in it. We had the HFA inhalers that have a propellant that'll actually get it into your mouth. The dry powder inhalers are going to be more kind of you're providing the inhalation, so or any of the propulsion there. So you inhale deep and get the drug into you. Yeah, so that's typically how you'd see most of those medications being administered, but not via nebulizer. Really, albuterol is like the main one. Sometimes you'll see levalbuterol via nebulizer as well. Okay. So then looking at inhaled corticosteroids, so these are going to be good for more chronic management. Again, how long do you think these would take to work? Think a long time? Like years?
No.
Probably not years. Think hours? So these are probably going to be, to get full effect from these drugs, you're going to be seeing more on the scale of weeks as far as efficacy goes. So these are not as fast acting as you would see with, say, like an IV dose of corticosteroids or oral steroids. These really take a long time in regards to, say, up to like 8 weeks to really see full clinical effect. And so it's really important when you put a patient on this that they need to take these very consistently. So frequently you'll see it dosed twice a day. They need to take it every single day as directed, otherwise they're not really going to see much of a difference. And then they're going to say, well, this drug's not very good. I'm still having asthma exacerbations, when really they're just not taking it appropriately, or they haven't given enough time to work. So kind of similar when we talk about antidepressants. Like, you need to give them enough time to work before you can make any kind of decisions on dose or the agent you're going to use. So you can see here, you've probably seen some of these before, budesonide, fluticasone, mometasone. Notice I put brand names for both the nasal form and the inhaled form for asthma. Notice how similar they look. So this is a big area for look-alike, sound-alike drugs. It's very common if you were just to put, say, fluticasone on a prescription, it could get misfilled if the pharmacist was not reading it appropriately, or if it was typed in incorrectly. So it's important in these cases at least make sure you're putting inhaled solution, or whatever it happens to be. Just putting the brand name is usually good enough. So Flovent to make sure you're actually getting the inhaled form. So again, they're working directly by inhibiting that inflammatory cascade, so they're working just like your systemic corticosteroids. They're just really limited to effects within the lungs itself, and really up to 8 weeks for the maximal effects there. The nice thing when you have some of the combination products we'll talk about, where they put a long-acting beta-2 agonist in conjunction with an inhaled corticosteroid, the nice thing there is that you get kind of some immediate action from the beta-2 agonist until you have the steroids really kick in. So this is kind of an additional benefit of using the combination there. Big adverse effects you're going to see is you can see oral candidiasis or thrush. And this is related to kind of a local immunosuppression in the lung. Because again, when you inhale some of these drugs, what's the first place it's going to hit? Should be the back of the throat, right? Your mouth, back of the throat. Like, that's where you see thrush. So it's a very important counseling point to make sure patients are washing their mouth out really good with water after they're using this medication. You also run the risk of maybe seeing suppression of growth in children, but this is a pretty high dose, so it's not something that is a frequent contraindication. And then again, rarely do you see any kind of systemic activity from these drugs, but theoretically could be possible. The 3 combination products that I have listed here, so you have, again, a combination of the long-acting beta agonists like formoterol or salmeterol in conjunction with a inhaled corticosteroid. So again, you get the benefit of having a long-acting beta-2 agonist on board immediately, while it takes time for the corticosteroid to really kick in. Okay, the next group of medications we'll talk about are going to be still on the controller side, or preventing symptoms from recurring. These are going to be our leukotriene modifiers. So we'll see there's kind of 2 groups here. One is going to inhibit the activity of leukotrienes at the receptor, and the other one's going to inhibit the formation of leukotrienes. So the first group here, the leukotriene antagonists, so these work against the receptor, are going to be zafirlukast and montelukast. Clinically, you're only ever going to see montelukast being used in practice. The reason for that is that because zafirlukast has some issues, I don't know what the beeping is. Zafirlukast has some issues with some hepatic impairment, but also, more importantly, it inhibits CYP3A4. So you're much more likely to run into drug interactions with zafirlukast than you would with montelukast. So that's why the other one gets prescribed much more frequently. Again, they're going to be working specifically by antagonizing the effects of leukotriene, the LTD4 receptor. I'm sorry, the cis-LT1 receptor, but that is the ligand for that is going to be leukotriene. Again, that's going to help to reduce inflammatory or reduce the inflammation there, bronchoconstriction, and mucus secretion as well. So all the things that are good. As far as potency goes, these are going to be less potent than you would see with, say, a corticosteroid that's working kind of from the top down. This is more working kind of directly at the receptors where those leukotrienes are being released. And you saw there's so many other different mediators that are involved in an asthma exacerbation that obviously this isn't going to inhibit all inflammation, but at least inhibits an important pathway. And so we'll talk about it being effective in aspirin-induced asthma in just a second when we look at how it actually works specifically. The other drug that'll be here, this one's pretty seldomly used as well. It may be used for more refractory patients if they've kind of failed other therapies. This would be Xyluten or Zyflo. This one actually inhibits the enzyme 5-lipoxygenase, so it works kind of similar to how an NSAID would inhibit cyclooxygenase to prevent production of prostaglandins. This one works on the thromboxane side. You saw lots of issues, things like flu-like syndrome. You also saw CYP interactions, and then you also saw more incidents of hepatic injury. So this one is frequently just going to be used for patients who are refractory to other drugs. So again, just some of the signs you can see with liver dysfunction that can happen with some of these drugs. So obviously, abdominal pain, nausea, jaundice would be kind of a big warning there. So as far as side effects go, the leukotriene receptor antagonists are pretty well tolerated for the most part. So montelukast is frequently used, especially I see a lot in pediatric patients with asthma. They tolerate it pretty well. I may get some stomach upset and whatnot, but for the most part, they do well with it. I think I'm missing that slide that had the leukotriene. I'll talk about it later if I don't get to it. Here, I thought I had the slide there though. So anyway, so other ways we can work is to remove the trigger or the antigen. So hopefully if we can prevent the release of inflammatory cytokines through that pathway, it can be useful. So we can have some mast cell stabilizers. So we talked about this previously. We talked about some of the ophthalmology meds. Again, limited use, limited actual clinical utility just because they're not all that potent compared to a lot of the other drugs that we have. So you can see things here like cromolyn, netocromel. Again, most of these have inhalation varieties. Remember when we talked about the mast cell stabilizers previously is that you have to take them before the actual insult occurs. So this would only be for control of symptoms and not for acute reversal of any symptoms that have already occurred. Because again, once the mast cells release their contents, they're already released. So again, these are the two that you see most frequently. Again, they take time to work. So again, up to 4 weeks and have to be taken regularly. Otherwise, they won't really see full effect out of those. And side effects wise, again, pretty well tolerated for the most part. Sometimes you have some bad taste in the mouth, but other than that, nothing too crazy. Okay, so then for major control of inflammation, say you've kind of run through all the other medications and really nothing's working, omalizumab or Xolair is going to be one of your go-to drugs. And so looking at the drug's name, does that tell you anything? Yeah, it's a monoclonal antibody. So this is a monoclonal antibody that is been derived and humanized IgE or against IgE. So basically, circulating IgE that's responsible for causing asthma exacerbation. This will be targeted against that, bind it up, and prevent it from activating that inflammatory cascade. So it's very, very potent, but there's a lot of drawbacks to the drug. So obviously, GI disturbances are possible, but with having a foreign protein being injected, you worry about things like anaphylaxis. There's actually some controversy around risk for having increased risk of malignancies, but nothing super definitive out there yet. So this would be a drug you'd give every 2 to 4 weeks or so. So usually we'll have patients like in our pulmonology clinic that will come in every so often for an injection of this, and you have to watch them, especially for the first few doses to make sure they don't have a reaction, say for an hour or two, and then after that you can kind of be assured that they're probably not going to have a reaction afterwards, but at least watch them for half an hour or so just to make sure they're doing okay. Again, anaphylaxis really being the biggest risk here, but you can certainly see other signs of an allergic reaction there, like urticaria and things like that. Okay, the next group of medications we'll talk about, these again will be even less frequently used. They used to be much more common, mainly because of the fact that they're fairly potent, but the toxicity profile of these drugs is going to be kind of nasty for us. So we have the methylxanthines. Does anyone know? The one I have listed here is theophylline. Also known as aminophylline. That's the kind of the IV formulation. Does anyone know of any other important methylxanthines? You might be abusing it right now. Caffeine. Yeah, caffeine. So theophylline and caffeine are actually chemically related. I apologize if there's any missing slides that you guys have on your copy. I uploaded a new copy recently, so you guys can find that on the site. I forgot to mention that earlier. Sorry about that. You guys can download that. It's up to date on Blackboard. Anywho, the methylxanthine, so theophylline being the main one here, it works as one is a non-specific kind of phosphodiesterase inhibitor. You guys remember any other phosphodiesterase inhibitors we talked about? So we talked about some with CHF. So remember we talked about like milrinone, Amrina, right? Those are phosphodiesterase inhibitors that are more specific for PDE3. These guys are going to be working against both 3 and 5 to some degree. So that'll be important when we talk about some of the interactions. But we also talked about some of our erectile dysfunction medications like sildenafil. Those are also going to be phosphodiesterase inhibitors here as well. So this drug is that you're going to be seeing that they're not quite as effective as a long-acting bronchodilator like salmeterol, something like that. But back in the day, before a lot of those drugs were developed, this is kind of all we had. They're less well tolerated, and they have a very narrow therapeutic index for the most part. So I'll show you some of the side effects you can see there. They can be associated with things like arrhythmias, convulsions, really bad stuff. So unless you are doing therapeutic drug monitoring for this drug and actually keeping track of the levels, you can really run into some issues. And so I'll never forget one of the worst cases I ever saw was this little old lady who was probably 84, 85, who was coming in from a nursing home and had an acute decrease in renal function. She must have been dehydrated, and they really weren't monitoring her. Was on theophylline. She came in non-convulsive status, and I mean, she ended up dying from that, unfortunately, but it's very easy to kind of go wrong if you're not using this medication appropriately. So most of the time you'll see it being used in patients who are either refractory to kind of everything else, or if it's a very old patient who has been maintained on this for decades and they just haven't decided to change them off of it. Again, theophylline you might see used a little bit more frequently as COPD, especially for patients who are refractory to other medications. But again, by working by increasing phosphodiesterase, that's going to help us to increase levels of cyclic AMP and also cGMP. And we know both of those are important for causing smooth muscle relaxation. Not only does that do that in the lung, but it can also do it in the vasculature as well. So if you get too high a dose, you can actually see hypotension from these drugs. And they also work as an adenosine receptor antagonist. So the 16 of you that watched the antiarrhythmic lecture have heard of adenosine previously. But for everyone else, adenosine is usually more of an inhibitory molecule. So if I were to say put it on the heart, it actually could stop it for a brief period of time. If you take away the effects of adenosine, you actually see more of a stimulatory action. So this is where you see a lot of the CNS effects, like seizures can occur by antagonizing adenosine, and also on the heart you can see more arrhythmias that can develop there. And then also it's thought to help with some of the late phase responses by decreasing some of the inflammatory mediators from being released kind of in that later 3 to 6 hour phase. So again, other things we can see, it has some diuretic effects. Can see stimulation of gastric acid, so you can see some GI effects from that. Looking at the levels, greater than 20 micrograms per ml is when you start to see more convulsions and arrhythmias. And if you look at the our therapeutic index on the next slide, you'll be able to see that usually 5 to 20 is a therapeutic level that we'd be measuring blood levels for to check where it's at. As soon as you get to 15 to 20, already you're starting to see some nausea, vomiting, starting to see some cardiac effects potentially. And then once you start to get above that, that's where you really start to run into issues with seizures and arrhythmia. So very narrow therapeutic index. And so because of that, we have a lot safer medications now, and we're able to transition most of our patients off of the methylxanthines. And then I put here it's renally eliminated, so that's a really important point. So if you don't adjust for renal function, or they have an acute decrease in renal function, they can accumulate this very, very quickly. And then once it gets into the CNS, it's hard to get out. So just for extra information, you can actually dialyze this drug off, hemodialysis, but once it's in the CNS, it's very tough to get out. So that's what that lady eventually succumbed to, is she was just in non-convulsive status and just really couldn't do anything else for her at that point. So bad drug. The one place I will see theophylline used, or more aminophylline, the IV form, is, at least in pediatrics, is when I have patients who have status asthmaticus, which we'll talk about a little bit later in the slide. Patients who are really, really refractory, they're basically on every other drug possible for status asthmaticus, and then they might add this one on for control, but then this is one of the first drugs to come off. So you might see it used acutely in the ICU, but usually not more than that, and certainly not for control of symptoms long term. Okay, so another group of medications we can see being used for asthma includes our anticholinergics. So these are going to be blocking directly the effects of acetylcholine on muscarinic receptors, right? So by doing this, you're going to inhibit, similar, it's kind of opposite to the effects of methylcholine. It's going to cause bronchodilation. There's a short-acting variety, so there's ipratropium or Atrovent. This one is frequently given along with albuterol, especially for an acute exacerbation, like say in the ER. You'll very frequently see orders for albuterol and ipratropium at the same time. There's actually a combo product called Duoneb that has both of them in it. And so I'll say that anticholinergics you probably more frequently see for patients with COPD just for long-term control, especially with the long-acting form, or Spiriva, or tiotropium is the generic name for that. That one's only marketed for COPD. So really, you don't see a lot of anticholinergics being used for asthma exacerbations, except if they're, say, in the ER and they're getting kind of the first initial couple doses of albuterol, they might throw in ipratropium as well, just to kind of give it a little extra boost to cause some bronchodilation. Spiriva is kind of interesting because it actually comes as a capsule. And so you basically have this inhaler that you would put it in, and there's a button you hit that kind of pierces it with a little needle, and then you can inhale it from there. And so it's actually one of the very, very common causes of calls to poison centers, because you have little old ladies or men who would call up and basically say, "Oh, I accidentally swallowed my Spiriva. What do I do? Am I going to die?" So we can kind of help them through that. Fortunately, nothing happens, but just kind of one of those interesting things. A good education point to your patients to make sure that, hey, keep this one segregated from your other pills, because they just put everything in their hand, just take it all at one time. So it's a frequent mistake. As far as side effects go, anticholinergics have this nice mnemonic to help you remember side effects that you can see with these. Again, because we're giving these drugs locally within the lungs, you're not going to see a lot of systemic effects, but just for completeness sake, these are things you can see as well. So we talked about it before, but you can see the blind as a bat, where they're having blurry vision, hemodriasis, mad as a hatter, so you can certainly see some CNS disturbances come from this. Red as a beet, so it'll be flushing. They'll have hyperthermia, dry mouth, dry eyes, it'll be dry as a bone, and then they'll also have decreased bladder and bowel tone. So you can see things like slow GI peristalsis, you can see urinary retention and things like that. And then tachycardia would be another. That'd probably be the most common clinical thing you might see with administration of these drugs, is that tachycardia, so a slight increase in heart rate. Okay, so then the third component, or one of the major components to an acute exacerbation not really being relieved by your short-acting beta-2 agonists, are going to be our systemic corticosteroids. So again, these are going to work from the top down through the entire inflammatory pathway, suppress, control, and reverse this airway inflammation. So again, like we saw with the mast cell stabilizers, you need to put those on before the actual insult has occurred. With these guys, it can happen before, it can happen during. It's fine, because it's going to work to decrease further production of inflammatory cytokines. So some of the common ones you'll see being used, certainly if it's less severe exacerbation, you can see things like prednisolone. It's just the liquid form of prednisone. You have methylprednisolone, which is a very frequent parenteral variety, right? So that's either going to be our IV, IM variety, and dexamethasone would be another one as well. That you could either give orally or parenterally. Dexamethasone is kind of nice from a patient perspective, because there's actually studies to show that you can get away with using a shorter course of therapy. Usually for these guys, you might use, like, say, a week's worth of drug. So for kind of a more minor exacerbation, you might give them 5 days worth of drug. So you guys ever seen those methylpred dose packs? Like a pred pack or something like that, where basically it has a sheet of the drug, and you take a bunch on day one, and they kind of taper down your dose over time. You've seen this before? Sure, someone has. Anywho, basically, by using dexamethasone, it has a longer half-life than things like prednisone, so you can actually get away with using a dose, say, on day one of the exacerbation, and then using a dose, say, 36 hours later, and the half-life of it is such you'll actually cover them for that full time period. So it's actually a good alternative, especially when your kid does not want to take medication. So usually you're going to see more short courses of these, usually 5 days or so, for more kind of moderate exacerbations that have not been relieved by some of your short-acting drugs. As far as tapering goes, if you're not using more than a week's worth of therapy, you really don't have to taper, right? Because the fear is, if I have corticosteroids on for a long period of time, what's that going to do if I were to immediately withdraw it? Rebound something. It's good. So your adrenal glands, right, they're normally the ones secreting a lot of corticosteroids into the bloodstream. So if they sense that they're getting exogenous steroids floating in the bloodstream, what do? Yeah, they slow down or stop production altogether. So if I were to have an abrupt withdrawal of those corticosteroids, the adrenal glands take time to really start to kick production back up. So you can run into a case where you can have an acute adrenal insufficiency that can be problematic for your patient. So if they're on it for more than a week, then you want to consider tapering down on your dose. Otherwise, if it's less than a week, you really don't need to worry about it. So again, a lot of the times you'll just prescribe one of those methylprednisolone dose packs that has a self-tapering, or has a tapering already built into it, but really it's clinically not really necessary. So just something to keep in mind. Yes?
So what happens if we just give them adrenal insufficiency? Like, do they just feel bad for a little while? Or like?
No, it can be like potentially fatal in some cases. Yeah, so if you think about it, like, you lose a lot of like your mineralocorticoid effects, so you have big issues with your blood pressure, right? So if you can't maintain fluid volume intravascularly, you can run into hypotension, tachycardia, other issues, really just all of your endocrine functions can be kind of screwed up. So blood sugar is going to be all over the place, things like that. So really be problematic. Yeah, there's they'll feel crummy, but they're also going to have some other stuff they probably need to go to the hospital for.
Okay.
Yeah.
Does that rule apply to the inhaled corticosteroids as well?
That's the nice thing about the inhaled corticosteroids is no, they don't apply it there, right? Because we're not really seeing a ton of systemic effect to it. So those just acting locally, it's okay. They're not really affecting our adrenal glands at all. Yeah, good question. So we can mention adrenal suppression, dermal thinning, hypertension. Again, that's a lot due to the fluid effects on the vasculature, which we talked about previously. You can see muscle weakness over time, immunosuppression. This is going to be more seen with patients who have kind of chronic autoimmune kind of disorders. So if they have like really bad rheumatoid arthritis or other autoimmune issues, this is where you're going to more see that. For acute asthma exacerbations, 5 days worth, you're really not going to run into a lot of it. You may see issues with the hyperglycemia. You may run into some CNS changes. Patients' kind of mood and behavior kind of changes some, especially in the elderly patients. You may see that more. So just be aware that that's going to be for the more short course therapy. A lot of times for patients who are having more severe exacerbations that actually get admitted is you'll start them off on IV therapy and then actually transition them over to oral, and then they might taper down off of that from there. So just looking at your pathway here, looking at how you would actually decide what kind of medications to use. And so it's just a stepwise approach, really. You kind of figure out where your patient's at to begin with, how severe symptoms they're really having, and you kind of change, kind of go up or down therapy based on that. So, initially, if they're really just having, say, if they're only having like exercise-induced bronchospasm, a short-acting beta-2 agonist is fine. That's all they really need. They don't need long-term control of their symptoms. Or if it's very kind of infrequent symptoms, say just around certain times of the year, or if they have certain exposures, they have an exacerbation, they may only need a short-acting beta agonist, right? So that's a SABA there. Once you kind of get more sustained symptoms or more kind of recurrent symptoms, that's where you want to consider using things like low-dose inhaled corticosteroids. So that's the ICS. They're probably going to have the least side effects and have the most kind of bang for your buck as far as therapeutic efficacy goes, right? If those are not working really sufficiently by themselves, then you may opt to add in that long-acting beta-2 agonist as a combination therapy, right? Usually, the other benefit of starting with just an inhaled corticosteroid is cost. A lot of the combination products, especially if your patient's insurance isn't real great, can be very, very expensive and can be cost prohibitive. So, kind of scale up your therapy. You can potentially increase your dose of the inhaled corticosteroid and see how they respond to that. But again, remember, give it enough time for it to really see if it's going to be working effectively for them or not. Again, all the while they're going to be keeping on their short-acting beta agonists for rescue therapy throughout this. Other things you could also consider in conjunction with the inhaled corticosteroids is you want to consider things like a leukotriene receptor antagonist, so something like montelukast you can consider. Actually, that's probably one of the only ones you really want to consider in conjunction with the inhaled corticosteroids. Once they start to fail all that other stuff is when you want to start considering things like omalizumab, but again, that's going to be chronic therapy where they're going in to have that injected every 2 to 4 weeks or so, and that can be very, very expensive. Because remember, any kind of protein products are going to be very expensive. And you just kind of keep scaling up. You keep increasing doses of your steroids, adding on other drugs to try and get final control of that. So does that make sense? Pretty easy, right? So again, if it's more intermittent symptoms, no really rhyme or reason to them, or they know the triggers, just a short-acting beta agonist might be fine. But other than that, you want to add on controller medications to help prevent them from having an exacerbation where that short-acting beta agonist doesn't do the trick, and then they have to go in and get systemic steroids. All right. So some of the things you may see being used in conjunction with meter dose inhalers are going to be these valve holding chambers or spacers. So the thing with getting drugs into the lung is that the particle size has to be just right. So if you imagine if the particle's too heavy, where is the drug going to end up? It's going to actually end up in the stomach, right? So if they're too heavy, they're just going to hit the back of the throat and they'll just get swallowed. And so if you actually look, there's a good picture, I should have included it, but basically they did some radio-labeled inhaled particles, and they had patients do an inhalation and then did a scan to see where all the particles landed. A small fraction actually goes into the lung. Most of it ends up getting swallowed. Just once it hits the back of the throat, it gets solubilized and just goes down. If the particles are too small, they're very light and they can be inhaled, but then they can be spit right back out, right? So there's really kind of a sweet spot where the particles are going to be small enough to where they can be inhaled, get into the airway without just getting into the GI tract, right? You're always gonna have some, but you try to get as little as possible. So technique is super important when using inhalers, because if they're not using it appropriately, or if they are, they don't have the mental faculties or the kind of muscular control, the hand-eye coordination to really use it effectively, you may not be getting much use out of the drug, right? Say the drug failed, but really it's just the technique that was bad. So spacers can be used to help with this. So spacers are usually like a long kind of cylindrical apparatus you're going to put to the end of the meter dose inhaler, then the patient would inhale out of that. One of the benefits here is that especially the speed with which you're inhaling particles can affect where it ends up as well. So a lot of them, if you inhale too quickly, it'll actually kind of whistle at you and kind of let you know, hey, you're inhaling too fast, slow down a little bit to get it in. The other thing is that these valve holding chambers you can basically just squirt the dose into the chamber will hold it, and then the patient can inhale it kind of at their leisure, or when they can. Otherwise, there's a much more kind of coordinated technique you have to use in order to actually get the drug into you. So that technique usually is that one of the things is always make sure that the drug is shaken up. Why do we do that? Yeah, some of them are going to be more suspensions, so you want to make sure to mix them up to make sure they're all, the drugs actually dispersed throughout the solution that you're inhaling. Other thing is with brand new inhalers, oftentimes they need to be primed, so you may need to do a couple squirts first just to make sure everything's primed to where when they get that first dose, it's going to be an actual full dose instead of just whatever propellant might have just gotten through. So the drug might not actually be all the way through yet. So it's important to let them know, and make sure they're exhaling completely. And then as they're breathing in, I tell them to start to inhale and then squeeze the canister down to get your dose. So that way you're kind of already starting up a stream going into the lungs that the inhaler, the drug can actually just kind of follow down. Oftentimes I'll see patients who will squeeze the inhaler and then inhale, and then that's usually it's all hit their mouth or the back of their throat, and they're just going to swallow a lot of it, right? So it's kind of this nice coordinated technique you have to use, and which is why the valve holding chambers are so much easier for patients, or a nebulizer as well. That's just kind of a passive, they're just going to inhale it, right? Either patients put it in their mouth, or they have like masks and stuff they can use for kids to help them just kind of inhale the drug passively. That makes sense for everyone? And again, for the inhaled corticosteroids, what are you going to tell them to do afterwards?
Rinse their mouth.
Yeah, rinse their mouth out, because again, you want to worry about that oral candidiasis. Okay. Then when they're breathing it in, make sure that they are breathing in very deeply. You want to make sure to get it as deep as possible to get to the site of action. Make sure they're holding their breath for at least 10 seconds or as long as they can to make sure the drug's actually going to be working. Otherwise, they're going to expire a lot of it. The other thing is I oftentimes will see patients who will just do like a quick 2 puffs to try to just get the dose in all at once. It's not really going to get as much efficacy as you would if you did the first dose, allow the drug to start to work, kind of relax some of those airways, and allow for deeper penetration of the next dose, right? So again, help them have a little bit separation there, at least 30 seconds, maybe a minute or two between doses. Okay, so anyway, so make sure, again, controller medication is really going to be key to making sure your patients are not going to be coming in for acute exacerbation, prevents hospitalizations. It's going to be very, very important for them. So make sure they're using the appropriate controller medication. Start out with an inhaled corticosteroid, and if they are not satisfied with that, then you need to bump it up and include that long-acting beta agonist. But never for these patients use the beta agonist, the long-acting ones by themselves, right? Because of that mortality issue. And again, always make sure you're kind of assessing your patient, like how often are they using their albuterol inhaler, because even if they're lying about their compliance with the controller medication, because again, usually if they're not feeling bad, they're not going to take their controller medication. How often they're using their short-acting beta agonist is a good sign of how well controlled their symptoms are. So try to get a sense of that so you can decide whether or not they're really well controlled with their other medications. Okay, so this is a new slide that you'll find on the uploaded variety. So I just wanted to touch on this briefly because we don't really talk about it elsewhere. But status asthmaticus, it's a medical emergency. Has anyone seen someone with the status asthmaticus? It can be pretty scary for some patients, especially if you have asthma. Ooh, that sounds really bad. But basically it's an acute exacerbation that really remains unresponsive to any kind of bronchodilator therapy. So they can use their rescue inhaler as much as they want, not really going to see much reversal of this. So just real quick, the pathway is the same as far as the pathophysiology of it. It's just a much more severe variety. I just want to go over the algorithm right here as far as, because you use some odd medications that we don't see used elsewhere very frequently. So one of them, obviously you start up continuous albuterol. So frequently you'll just have a nebulizer that's just running continuous albuterol, and you can actually change your dose based on the concentration that you're administering to the patient, or the concentration you're putting in the nebulizer cup. So you kind of titrate the dose based on how well their symptoms are responding. And then some of the other medications we can add on as well. So obviously they're going to get steroids. Usually at this point they're considering status asthmaticus, you're going to use IV steroids, just because if they are really kind of worked up and they're very anxious, it could be tough to get oral meds into them. Another thing we use that you wouldn't think of for asthma is going to be magnesium. So you can actually give IV bolus and continuous infusion of magnesium in order to help control these symptoms. And why do you think you could use magnesium? Doesn't help it become absorbed. So it comes up if you listen to the antiarrhythmic lecture, so hint, hint. So magnesium is kind of like the body's natural calcium channel blocker, and so it actually helps with smooth muscle relaxation. So one of the frequent side effects you see with magnesium being given in big IV doses, like too quickly, is you can see hypotension, you can see flushing. We're kind of going for those same effects here when we're giving IV magnesium, and so there's actually been some studies showing benefit for patients who receive IV magnesium during status asthmaticus. You can actually hasten their time to recovery by giving this additional smooth muscle relaxer. So you'll see magnesium being used. Another one, especially if the patient ends up becoming intubated, is going to be a sedative called ketamine. Has anyone heard of ketamine before? Yeah? Anyone else? Kind of the infamous reason for ketamine?
Date drug.
Yeah, date rape drug, right? So ketamine frequently used as kind of like a veterinary anesthetic. We use it a lot in pediatrics, especially for patients that need kind of brief sedation for things like dislocated fractures and things like that. The reason why we use it here is, one, especially if your patient's really kind of ramped up and anxious, they can kind of help chill them out because it has this nice sedative effect. It works as an NMDA receptor antagonist, and so NMDA is an important receptor that interacts with glutamate. If you guys remember, glutamate is an important excitatory neurotransmitter. It's kind of the opposite of GABA, which GABA is going to be a major inhibitory neurotransmitter. So basically by inhibiting this NMDA receptor, you get this dissociative anesthetic effect, and so it's kind of like an out-of-body type of experience, which is why some people abuse this medication. But the other big thing it does is it actually increases release of catecholamines like epinephrine, norepinephrine, so you can end up seeing bronchodilation from this. So if you have an intubated patient, you need to sedate them. This is actually the go-to drug for status asthmaticus due to this effect. So it's kind of a nice benefit there. Again, it's going to have sedation effects, obviously, so that's one of the big things. The benefit here is that it actually doesn't inhibit your respiratory drive like you would see with a lot of other sedatives. So we'll talk about that next semester, most likely, but a lot of sedatives will decrease respiratory drive. This one doesn't do that, which is another benefit. As far as adverse drug reactions go, you worry about things like hypertension, tachycardia, vomiting, but you also have this idea of an emergence phenomenon, which is basically when a patient is coming out of ketamine, so you stop the drug, they have a higher risk to have this emergence phenomenon where basically they wake up very agitated, very confused, hallucinating potentially, and can be very, they can be a harm to themselves, others. They can start ripping lines and trying to punch nurses and all kinds of stuff. See less of that with children, but in adults you end up seeing a higher rate of emergence phenomena actually occurring. So just be aware that that's something that can happen. And then also aminophylline might be another one you can use if everything else has kind of failed. Typically you're adding these drugs on as a stepwise approach. So you continue the albuterol, you add on the magnesium, you add on the ketamine, and then also if they're kind of refractory to all of that, then you may add on aminophylline as that methylxanthine to get just a little bit extra smooth muscle relaxation there. So again, infrequently used, usually they're in the ICU if they're at that point. So any questions on that? Yes?
I've seen them at the ER where they give magnesium with gluconab. Do they just randomly do it, or
No.
reason?
Yeah, usually they'll start the patient off on a duoneb, and that's that ipratropium plus the albuterol, right? So sometimes it's either together in one, or they'll have two different nebules they'll put in the same thing. Usually based on their symptom severity, they'll decide to do the magnesium. So magnesium will be given IV. I don't know if you've seen it where they give it else.
No, I haven't seen it.
Yeah, so IV would be the route that would be given by. So again, if you can kind of look at a patient, kind of get an idea of they look really bad, they're tripoding and they're having all kinds of issues. Their O2 sats are starting to drop. Okay, you probably need to start being much more aggressive with it. So that's when they'll kind of throw on the magnesium at the beginning. Otherwise, you might see some patients who you're giving the albuterol to and they don't get any better, and then at that point you may consider doing a bolus of magnesium. If that seems to help, then you can give them a continuous infusion. That's usually going to buy them at admission at that point, though. Any other questions? All right, I'm just going to push through this final bit if you guys don't mind.
Keep going.
Yep, all right. Someone wanted to get out early today, so I said, all right, I guess I'll try. All right, so next we'll talk about COPD, chronic obstructive pulmonary disease. So you'll see a lot of the same drugs being used here as we do with asthma, just a little bit different order you might administer them in. But we know this is going to be a chronic inflammation of the airways. We're going to have damage to the lung parenchyma over time, and often it's not going to be fully reversible. It's the big thing here. So they're always going to have some degree of impairment in the lung tissue just due to this chronic inflammation. So basically you see this accelerated decline in the FEV1 that's not going to be reversible with a bronchodilator, or at least fully reversible. So you can see here that over time the red line is going to be their FEV1. You can see that they can remain asymptomatic for a good long time as they're kind of destroying their lung tissue, and then eventually you're going to see the symptomatology start to really kind of ramp up towards the end there. So unfortunately it's not one of those things you can catch as early as you like. You just try to target those patients who are at biggest risk, and who are those patients who are at big risk? Yeah, smokers are at the biggest risk there. They're doing damage chronically, but again, it could be a while before they really start to see the ramifications of that. There's other reasons you could have an alpha-1 antitrypsin deficiency. Even things like indoor air pollution has been seen to be linked with COPD. But yeah, smoking is going to be your number one cause there. So we'll talk a little bit about, those are going to be some other new slides that I added. They're talking about smoking cessation that will be at the end of this. Okay, so this table kind of has all the different medications and kind of the stepwise approach that you would add them on for your patients with COPD. Again, a short-acting beta agonist is going to be useful for acute symptoms, so they're having acute exacerbation. And sometimes you have patients who will have kind of degrees of asthma on top of COPD and vice versa. So again, short-acting beta agonists can be useful up front for rescue therapy, so they'll always have that on board. You see here that's right here we're starting off at. Notice here there's going to be some kind of long-term effects or long-term things we're going to be looking at, like vaccinations and smoking cessation, so we'll talk about that at the end. After that, then you want to look at starting to add on long-acting inhaled bronchodilators. So you could potentially do a long-acting beta agonist by itself. More often they'll be started on a long-acting anticholinergic as well. So it could be one or the other. Eventually at some point they might be put on both. But yeah, long-acting bronchodilator would be next. So like your tiotropium, your salmeterol. And then after that, you want to consider combination of the anticholinergic and the beta agonist bronchodilator. So you might be on both drugs at the same time. At this point, you can consider theophylline. So sometimes you'll see theophylline being used for those patients, but really just due to that narrow therapeutic index, oftentimes people are pretty gun-shy to start it. So more frequently, they'll get put on an inhaled corticosteroid, right? For really severe patients, you may see them on either kind of recurrent, kind of pulse doses of steroids they might be on whenever they had an exacerbation, or they might be on kind of long-term inhaled corticosteroids as well. So you kind of might see one or the other. Then eventually they're still failing all of that therapy as time goes on, because really you can't reverse any of the damage. You're just trying to help stave it off and help to prevent further progression. Obviously the final thing to do would be surgery and transplant, but a lot of patients don't necessarily get that far. So that makes sense how you do here? So again, short-acting beta agonists for rescue therapy, then add on more of a focus on long-acting anticholinergics and beta-2 agonists for controller therapy, and then you'd add on the steroid later. Okay, so as far as smoking cessation goes, it's a major contributor. A lot of patients who smoke are going to develop COPD, especially if they are, the longer you go, the more likely you are to have it. And how often is smoking cessation successful? Not super often. A lot of people, it's a highly addictive chemical. Obviously, the addictive component is nicotine, which acts on what? It should act on nicotinic receptors, but again, that doesn't really explain the addictiveness. Really, it's dopamine is going to be the big thing here. And so that'll be important when we talk about one of the medications we'll use to actually help patients quit smoking. But activating that reward pathway with dopamine is going to be is really strongly linked to the addiction that develops. So we'll look at a drug that's actually going to affect that pathway a little bit later. So there's going to be lots of different medications we can try to use to help get them off. So sometimes you'll see combination therapies, but it's important to look at the mechanisms to make sure that they actually make sense when you're adding them together. So a couple of different ones here. Bupropion, sustained release. There's a formulation specifically for smoking cessation called Zyban. Does anyone know where else you might see bupropion being used? Yeah, it's antidepressant. It's actually an antidepressant. This one, a lot of antidepressants, they're called SSRIs, or selective serotonin reuptake inhibitors. So they work to block reuptake of serotonin that's been kicked out of the synapse, right? So they block the recycling of it. Bupropion is a little bit different because it actually works to block the reuptake of dopamine. So you have a little bit of serotonin reaction, but you're also going to have more effect on dopamine. So the idea is if you have a patient who is, craving nicotine, right? They're not really getting that dopamine reward center really activated. By giving a drug that's going to kind of subtly increase levels of dopamine by preventing reuptake, hopefully you can help them to crave some of those cravings, right?
Is the Zyban different than what they get for SSRI?
No, it's just marketed for that specific indications, and then they get like a whole new patent that they can charge a lot of money for.
Actually?
Yeah.
So you're saying it increases the dopamine circulating?
In the synapses and in the CNS, really, it's not more systemically, mainly just in the CNS. You're going to be seeing the effects there. Yep. So anyway, so that's one way to do it. So it's kind of we'll save talking more on that until we get to the psych lectures next semester. But just know that that's available. You can also replace the nicotine. So the idea here is instead of them smoking and getting their doses there, where they're kind of self-titrating, right, to how many ever cigarettes they smoke a day or whatever it happens to be, you would hopefully give them a gently titrating dose where eventually you can get them off of it, right? So lots of varieties. Some of them are going to be over the counter, some of them are going to be more prescription, but certainly things like the gum, inhalers, things like that you can find over the counter. Patches are available as well. So again, the idea would be to replace the dose they're kind of getting, start to do a gentle decrease, and eventually, hopefully you shouldn't get any cravings, but of course it's not always going to be super effective, right? So the important thing here is to tell them to not do what when they're on these? Not to smoke, right? So again, what's the only thing they're going to want to do? They're going to want to smoke, right? Because then they're getting way more nicotine than they probably were used to, and then all of a sudden now their body's kind of getting used to even higher dose of nicotine than what they're on previously. So that can be an issue there. So it's important to let them know not to smoke. And then there'll be this other drug called Chantix or varenicline, which we'll talk about in just a second. That's kind of the newest agent that we see used for smoking cessation. So again, bupropion, it's going to be increasing levels of dopamine in the CNS. So again, it's trying to mimic that kind of reward pathway a little bit. There's actually another indication you might see this being used with weight loss. I believe there's a combination product. It's either out or coming out. It's actually bupropion plus another drug called naltrexone that is actually thought to help deal with like food cravings and things like that to help with weight loss. Again, this is the same variety you would see being used for treatment of depression. It's just a different brand name. So if you can get the generic, just do that. Certainly, because we are increasing levels of catecholamines within the CNS, you worry about interactions with either one other antidepressants. So you can see serotonin toxicity. Patients who have seizures may have their seizure threshold reduced, so maybe at more risk for seizures, and can be an issue there. And so just be careful adding it on with other drugs that are kind of either pro-serotonergic or pro-sympathomimetic, because you can see interactions there. You can see increased blood pressure, heart rate, things like that. Again, the nicotine replacement designed to help kind of reduce the craving to smoke, kind of minimize a lot of the physical withdrawal phenomenon that you can see there. So certainly your body's used to nicotine. If you cut off cold turkey, you're going to have kind of those withdrawal phenomena because your body's kind of maintained, the new normal for your body is to have that nicotine around all the time. So it can be a big issue, and that can oftentimes lead to, go right back to use. That's why cold turkey is kind of very limited success rate. So again, by giving this, you minimize some of those withdrawal effects, and then hopefully they can just titrate their dose down over time. So you can patches, gum, you can get over the counter, but there's other varieties as well, so you can get like the actual inhalers. Certainly, if you have patients who have cardiovascular problems, or if they're smoking along with the nicotine, you can see increased risk for things like arrhythmias. CNS issues can also be a problem here as well. So again, make sure they're at least aware of the risk there. If they're having any kind of symptoms, let you know that hey, maybe it's time to switch over to something else. So potentially you could use something like bupropion and the nicotine replacements, because again they are working on different pathways, right? But you wouldn't want to use kind of multiple nicotine replacements. And then does anyone know anyone that's tried to quit smoking with some of the new e-cigarettes? The vaping? So that could be a potential, probably going to be looking at long-term health studies, years from now to see how these patients or, these people are doing. But that could also be another route. So, the big issue with some of those we run into is actually going to be kids getting into a lot of the vape liquids or the e-cigarette liquids. They actually contain really highly concentrated amounts of nicotine. So we've seen some issues where kids will get into that and have really bad CNS effects from that. Not only that, but nicotine gets really well absorbed through the skin. So even like just touching it can have some issues for kids. So that might be another route. They may not want to go with one of the traditional, routes for nicotine replacement. They try to do that with e-cigarettes, and some people do have good success with it. So if it works for them, say go for it.
Question.
Yes.
Is nicotine inherently carcinogenic by itself, though?
if it does, it's not nearly to the degree that you would see with a lot of the tar and stuff that you're inhaling with because it's not only even the other carcinogens that are in the actual cigarette itself, but it's also just the temperature of the smoke that you're inhaling does a lot of damage to the lung tissue as well. So at least with like the vaping, it's it's vaporized within the thing, and then you're inhaling a much cooler gas. So that's thought to be helpful as well. I don't vape, even though I drive a Subaru. So just so you guys know, seems to be the popular conception, but no. Anyway, I just vape my inhaler. And blow some sick rings. Anyway, so then varenicline is going to be the newest agent. This will be Chantix. So this one's really kind of interesting because this is actually a partial nicotine receptor agonist. So instead of having nicotine fully activate those receptors and try to taper down your dose with a nicotine replacement, this one just kind of sits on the receptor and just kind of partially activates it. So the idea is you would have, you kind of decrease those cravings, decrease those withdrawal symptoms, and even if they were to smoke, you don't necessarily see an additive effect there because of the fact that those receptors are already occupied with something, right? It's kind of binding a little bit tighter. So they shouldn't smoke, but they can. If they do smoke, it's not going to be as big of a problem as if they were smoking on top of having a nicotine replacement, right? Because again, there's only so many nicotine receptors to activate, and these guys are already sitting there, or the drug is already sitting there to block it. This does have pretty good success rates with it, at least relative to other cessation methods. One of the big things you're going to see, though, is that you can see big sleep disturbances. Like people talk about like just insane dreams they have, very vivid dreams, very odd. So that can be one thing that may be problematic for your patient. Some people love it, who knows. But then the other thing is there's actually a black box warning associated with it. So you can have increased neuropsychiatric events like depression, suicidal ideation. So let your patients know, let their family know that if you see anything like this, like we need to know about it so we can get you off this drug and try something else. So just another risk to worry about. Patients with COPD, they really need to keep their immunizations up to date because otherwise they're to some degree immunosuppressed because their lung tissue just doesn't have that normal protection pathways the healthy tissues would. So for those patients, they really need to make sure they stay up to date with their influenza. So every year they need to get that. And they also should be up to date with their pneumococcal vaccine. So they have not received that. I think it's either 5 or 10 years. They do need to get that re-updated just to help protect them from having that, because that can be a big source for, you have an infection, you have an exacerbation of your lung function, get put into ICU, and then that's kind of where they get you, right? So vaccinating is going to be important to prevent that. Okay, so any questions on the pulmonary stuff? All right, go out and watch your antiarrhythmic lecture while you're watching the statistics. All right, thanks.